So this is a very hot topic. I just trying to make it simplify regarding the blood physiology and coagulation, the cascades, the drugs, and all that. The most important thing is what is important is control of blood loss. That is called as hemostasis. So hemostasis. This is achieved by what are the major components suddenly after injury. The first thing that happens is vessels vasoconstriction. Then whenever there is injury, there happens platelets come into action and they form a plug, that is called as platelet plug formation to prevent the bleeding. These two form the primary hemostasis. Now it has stopped. Now this injury anywhere here will lead to activation of a cascade that is called as coagulation cascade. Now this coagulation cascade, it is because of tissue factor that forms thrombus. So this thrombus is formed by thrombin. So this thrombin activates fibrinogen to form a fibrin. So fibrin is ultimately forming a blood clot. Now this is the mechanism for coagulation. Now it has to be balanced. Clot is formed. Now this clot is broken down into fibrin degradation products by plasmin. So two things are happening at a time. Hemostasis involves the balance between at one side, that is called as, if suppose your bleeding is there, at opposite side there will be thrombosis. One side is bleeding. Now this bleeding is stopped by factors like vasoconstriction, platelets, and coagulation. On the other side, thrombosis is prevented. It is also called as anticoagulation. Anticoagulation means you want to prevent automatic thrombosis inside the vessels. This is very important. We don't give much importance, but actually most of the drugs and all there are for the anticoagulation. So it is we called as anticoagulant. It is by three things: protein CS, antithrombin 3, and third is plasmin, which leads to fibrinolysis. So coagulation will form clot and clot will be broken down. These two, the balance in this will be the important thing. Now let us see how each work. Let us see first platelets. Vasoconstriction we all know. So platelets, very important action. They have got three types of granules: alpha, delta, and lysosomes. Alpha granules, they secrete many like fibrinogen causing aggregation, von Willebrand factor causing adhesion, platelet derived growth factor leading to tissue repair, chemokines leading to inflammation, and factor 5 plasminogen activation inhibitor leading to coagulation. Delta granules secrete serotonin, vasoconstriction, calcium ATP for coagulation. Lysozymes secrete proteolytic enzyme. So this was the function of platelets. Now coming to coagulation, this is more important. Now coagulation has, everyone knows, intrinsic and extrinsic. Intrinsic is activated by subendothelial damage, subendothelial, and this is activated by tissue trauma. Intrinsic starts from 12, 11, next is 9, 8, these are the factors. Then last is 10th. 10 is activated. So this is intrinsic long factor. This starts from 3, 7, 10. So activated 10 converts prothrombin, it is also called as factor 2, to thrombin. This thrombin converts fibrinogen to fibrin. This is fibrinogen is factor 1 and fibrin, stable fibrin are fibrin clots. So this is fibrin clots. Now this is what we have seen on one side: bleeding, vasoconstriction, coagulation cascade, extrinsic, intrinsic. Now at the same time, on opposite side, anticoagulation is happening, against coagulation. So three important, again in anticoagulation there are three important parts which are playing. Just in the beginning I have read protein. First of all, let's see fibrinolysis. Fibrinolysis. What is this? End product was fibrin. This has to be broken down. So what happens? There is a substance called as plasminogen. Plasminogen, which is converted to plasmin, that breaks the fibrin. Just remember this. So plasminogen is converted to, gen is always primary product, then that is final is plasmin. This is activated by TPA, tissue plasminogen activator. This TPA, the question is this. Now we are using one drug called as tranexamic acid. Tranexamic acid, which acts on this plasminogen. So whenever there is bleeding, you are just inhibiting this plasminogen, so it will not form plasmin, so clots will not be dissolved. So that is called as anticoagulation. So clots, it is after formation of the clots, they are dissolved. So this will not lead to clot formation. Now next two are protein C and protein S. Where do they play role? Here the drug is warfarin. Just remember warfarin. These are vitamin K dependent. 1972. Among this, just choose in this. 7 is there, 10, 9, 10, 9 and 2 is this. On this warfarin is acting. So there, remember one word, thrombomodulin. Modulin. This forms with thrombin a complex. This complex activates first C, then S comes in between. They both join together. They go there where the clotting cascade is there. They inhibit 5 and 8. This is 5 is always In between this 5 is acting Abel factor or something. So 5 and 8, and that causes again activates plasmin to break down this products. So it is acting on the two sides. So to inhibit this action, we use the last way is here is the warfarin. The third part is, remember, antithrombin AT3. It is related with heparin. AT3, it acts on 2, 9, 10, 11, 12. 2, 9, 10, 11, 12. So here is this 11, 12, 2. If you see 12, 11, 2, 9, 10. 1, 2, 3, 4, 5. 2, 9, 10, 11, 12. If you see, these are all intrinsic. So heparin is acting on intrinsic. This heparin, while 1972, 7 is there. That's why warfarin has come in the extrinsic as well as here. So this is a long pathway. We test APTT, and this short pathway we test PT. So this is about coagulation, anticoagulation. If you want to see this detail, just go this chart, see this chart, save for some time. This is intrinsic pathway, this is extrinsic pathway. Factor 12 is the first activated to factor 11, 9, 8, 10. Hegman, plasminogen. Why the names are important? Because whenever you get factor 8, anti-hemophilia A, this is anti-hemophilic A. Factor 9 is Christmas, Wall-Bilden-Wab disease. Factor 4 is calcium. Factor 5 is labile factor, calcium. So von Willebrand disease, hemophilia A and B, factor 8. What is raised in hemophilia? HAT, APTT. And von Willebrand, what is raised? WAB, APTT and bleeding time. What is tested in intrinsic factor? Intrinsic factor tested is APTT. And what is tested in extrinsic factor? PT. So what is tested? Intrinsic factor. Intrinsic pathway is more dependent on heparin, blocked by the heparin. Extrinsic pathway more blocked by vitamin K dependent, that is warfarin. So warfarin we are testing prothrombin or INR, while in this heparin we are testing APTT. Now deficiency of any of this factor leads to bleeding tendencies of this. Deficiency of this 8, 9 leading to bleeding disorders, while deficiency of this extrinsic pathways like stable factor, and there are many factors like factor 5. Now what are the thromboembolic disorders? Now in continuation this, if you try to understand some of the disorders like hemophilia A and B, X-linked, this is 1 in 10,000. So what happens? Spontaneous mutation. It can happen because of weight bearing joints, bleeding in weight bearing joints. And hemophilia B is also X-linked. It is 1 in 1 lakh, 100,000. So this is very more common. So in this deficiency you get factor 8 concentrates, while hemophilia B is because of deficiency is factor 9. This is because of factor 9. It is also called as Christmas disease. That's why Hemophilia, here you can see Christmas factor. Factor 9 is Christmas factor. So hemophilia B is a Christmas disease. This is Christmas. And von Willebrand factor, von Willebrand's disease, it is basically used for von Willebrand's most common. This is most common, 1 in 800. It is plasma glycoprotein. This is one question. And it is carrier for factor 8, and it helps in platelet adhesion. In the beginning you have seen platelets here, platelet plugs, and this forming. There von Willebrand factor is important. So von Willebrand, we test VAB, bleeding time, as well as APTT. VAB, BT is bleeding time. So bleeding time is platelet function. There are 3 types in VAB also, von Willebrand's. Type 1, 2, 3. Most common is 1. It is autosomal dominant. There is reduction of quantity is reduced. And type 2 is variably inherited. There is defect in VWF, and this is very rare. So most common is this, quantity is reduced. So there is features are mucosal bleedings. Here you give cryoprecipitate. So as you have seen, vitamin K is deficiency. One of the bleeding disorder will lead to vitamin K deficiency. Factor 2, 1972 factors, just like which are dependent on warfarin. Hepatic failure, again CNS proteins, renal failure, and all this. These were about the bleeding disorders. If there is deficiency of factors which leads to prevention of coagulation, this is on this side. This is anticoagulation. If any factors are deficient, that will lead to clotting disorder. So this is left side was bleeding disorder, right will be clotting, also called as thromboembolic disorders. Now these are congenital absence of factor 5 laden, antithrombin 3 deficiency, protein C and S deficiency. These are the congenital. Acquired is disseminated intravascular coagulation, thrombocytosis. So this is the balance of hemobleeding and coagulation. Excess or deficiency on the left side will be bleeding. On this left side, deficiency will lead to bleeding. On this side, any deficiency will lead to thrombosis. This is the basic thing which you have to understand, the drugs, the diseases related with the blood coagulation. I try to make it simplify. I'm not going much detail. Let's see, this is important for exam point of view, and we are getting a lot of confusion. That's why I try to simplify it.